Study for briefing and discussion.
Wonderful, thank you. And can we be please joined at the table by Jeff Sakuma, Leslie Price, Beth Gappert, Katie Tassery, Meg Oberland, and Karen Hartfield. We have a full table. Welcome. And I think you have some name tags as well. If you can help put those out for us, that'd be great. And take your spot. You haven't. This may be more for me than anyone else.
And I'll come around and bring you yours.
So thank you so much for joining us at the table. We're going to have about 30 minutes for this discussion, actually. We really appreciate this initial briefing. As I mentioned, we're going to have a full committee presentation at our April 19th committee. I want to make sure that we have a chance to really get into the recommendations, I should say the initial recommendations that came from the statement of legislative intent here. And before we begin, if we could have folks introduce themselves for the record, and we'll start over here.
I'm Karen Hartfield, Public Health, Seattle, King County HIV STD Program Manager.
Katie Tassery from the City Budget Office.
Beth Gappert from FAS.
Meg Olberding from the Human Services Department.
Leslie Brinson Price from the Mayor's Office.
Jeff Sakuma from the Human Services Department.
Wonderful. Thank you for being here. And thank you again for presenting on the statement of legislative intent. Please go ahead.
Sure, I'll kick us off. So Councilmember, good morning. We are happy to be here to express Mayor Durkin's commitment to move forward with...
Welcome, Councilmember Gonzalez. Thank you so much for joining us.
Thank you. Good morning. Exactly. So we're here to express Mayor Durkin's commitment to move forward with efforts that will help prevent opioid use disorder, improve access to treatment, and prevent overdoses. Ultimately, our #1 goal is to save lives. I think we've heard a lot this morning and want to reiterate our commitment to moving forward with not just this one recommendation around the community health engagement location, but with a number of efforts to reduce the impact of the opioid crisis. We are in the middle of a public health crisis. In 2016, there were 352 drug-caused deaths, almost one every day. 64% of these were related to opioids. It's a tragic statistic when we consider that it's possible to reverse opioid overdose. We are seeing increased fentanyl in our community. At least 9 of the opioid-related deaths involved fentanyl and other synthetic opioids, whose potency can be multiple times greater than heroin. And heroin is now the most commonly reported primary drug for all treatment admissions in the county. As a result of the King County Task Force on Heroin and Prescription Opiate Addiction Task Force, I have it twice, we're working to better confront the challenges of addiction. We've made nearly 2,800 life-saving naloxone kits available to law enforcement and treatment providers so they can reverse the effects of overdoses. We've started a pilot project that offers rapid access to buprenorphine medically assisted treatment at the Needle Exchange operated by Public Health Seattle King County. We've also helped open a new detox facility that will offer integrated treatment for mental health and substance use disorder, including opioid addiction. Today, of course, we're here to discuss the executive's response to the statement of legislative intent, and I'll turn it over to Jeff.
Great. Thank you very much.
Welcome, Jeff.
Hi. Though you didn't ask us, I was born and raised in District 2.
Okay,
and
good. Thank you.
And I've lived back in District 2 for the last 25 years.
So a dig at me, wasn't it? I know it was.
As you know, that there were 3 major areas of recommendations from the heroin and prescription opiate task force. Those broke down into 3 major areas. There were 3 recommendations around prevention. There were 3 recommendations around treatment expansion and enhancement. And then there were the 2 that were related to user health and overdose prevention. I won't go into all the details. I know that we've been at this table before talking about all of those recommendations. But again, the 2 that were related to user health and overdose prevention was the access to naloxone, which has increased greatly over the past couple of years, much due with the work of public health. And then the second is related to the community health engagement locations or the supervised consumption sites. And again, I use those terms when I talk about it. I use both terms. I want to be clear that we're not trying to disguise anything, that they are supervised consumption sites, but the community health engagement piece of it is equally important, that these are locations where we're obviously bringing people inside, wanting to engage them and to help them sort of move potentially beyond heroin use and addiction and into other treatment and services if need be, or if desired. The community health engagement locations that over the course of the time, over the past year plus, after the recommendations came out from the task force in September of 2016, that at that point, after that, both the then mayor of Seattle and then the King County executive affirmed the recommendations in January of that year, as did the Board of Health have an endorsement in January of that year. The recommended, after that, there was a subgroup that got together and produced recommended guidelines for what a community health engagement location could look like, and those were published in February of 2017. As was referred to previously, there was a process an initiative process to disallow CHELS from moving forward, which was then ruled out in King County Superior Court. And that took us through the fall of 2017, and then with the council actions with both the SLI and the budget action in November. That kind of takes us to where we are today and sort of the development of the SLI. The SLI itself had 4 pieces to it that we were responding to. So first was the description of community health engagement process, including timelines, estimates for capital cost and initial costs and operations, a narrative describing division of shared responsibilities among the city and King County and operating a safe consumption site, and then the narrative describing the division of shared responsibilities among the city and King County in operating a safe consumption site. And I think that I will now turn this over to Beth.
Meg.
Oh, Meg. Sorry, Meg. Oh, give me.
Good morning. Thank you for having us. And also, I want to thank the folks who spoke earlier to keep this front and center about the crisis that we're facing and the need to move forward. So the community engagement really is about working in tandem with the citing process. We don't need to start over. There have been folks working on this for 2.5 years at least, and to bring this forward. And so it's really about making sure that we build on that and we can continue with community awareness to keep the crisis front and center, but also as we cite, we are working in tandem with the stakeholders in the vicinity of the site to make sure that we support their needs. And that, that includes businesses, other nonprofits, health-related care that might be in the area. It's making sure that they're getting the supports that they need. So one of the things that I think is important as we build this partnership effort is really to work on that two-way communication effort and make sure that we stay pretty close to the folks in the vicinity of the site. And so wanting to make sure that we learn from some positive models like we've done through the community advisory councils with the encampments that we've cited, and working very closely with the communities, and that's been a very positive model for us to look at. And also learning from not so successful models like the Navigation Center, making sure that we learn those lessons, and as I said, really stay in touch with the community and keep that two-way communication open.
Chair Mosqueda. Yeah. So when you're, Meg, when you say models that don't work, I just want to make sure that we're clear that when you're using that language, you're talking about the community engagement model, not the intervention chosen. Correct?
Yes, thank you for that
The
clarification.
Navigation Center is a model that we have
we're talking
invested in, and we know that that's a smart model and a good place for us to make an investment. And similarly, this intervention, public health intervention that we are moving forward with is also a good intervention and a good model. So I just want to make sure that when you say model, you're just talking about the community engagement aspect of implementing a policy direction of the city.
Correct. Thank you for that clarification. Absolutely.
Thank you. First of all, thank you, Meg. I know we've all been looking at this for a couple of years. Councilmember Gonzalez and I both sat on the Board of Health, and like I said, I'm still on the Board of Health with Councilmember Mosqueda now. I have two questions, and we went over this with our staff too, just to kind of make sure we understood because I co-sponsored the slide with Councilmember Johnson. There isn't a timeline set in here on community engagement on the community. There's no timeline set, I notice. And the other issue is, and I know Councilmember Gonzalez is going to spot this as well, when they do the siting evaluation or the community engagement process, I mean, whether or not there isn't any mention about the Race and Social Justice Initiative, those two issues. So my two questions are the timeline and the race and social justice when you're doing the siting piece, because that, as you heard my comments earlier this morning, everyone agrees about what's happening, but where the sticking point is, where the heartburn is, what people are concerned about is the siting. And that's why you had 5 cities pass ordinances that did not want them in their city. Correct. It had to be overturned. So that's really where the issue is right for us. So those two issues, can you address those for me?
Sure. So the timing of community engagement is not separate and apart from the siting. It's in tandem with the siting. And it really is about making sure that as we hone in on a site, that we are working with the stakeholders in the vicinity of the site to make sure that we're walking in partnership with them. So it's not a separate process that is apart from the siting process. It really is in tandem with them. And that's really why there's no specific timeline yet. One is that engagement has already been happening, so it's ongoing. And the second piece is that really as we look at the options for the kinds of sites we could be working on, which Beth will talk about in a minute, we'll be able to hone in on what is needed for that to open up that two-way communication with the stakeholders in the vicinity. And so it's an ongoing timeline, and it's in tandem with the siting. And then the second question you had was about the RSJI. And certainly the city's RSJI toolkit involves stakeholder and community engagement in looking at the disparities and in coming up with the proper benchmarks for race and social justice. So that will be a key part of that, particularly as we look at the impacts of this crisis.
Thank you, Meg.
I just want to flag that I think it's precisely because this has been an ongoing conversation, as you heard from the folks who presented this morning, and Councilmember Juarez and Councilmember Gonzalez have been involved in this along with Councilmember Bagshaw and the rest of council for a long time. And I think that what you're hearing from folks is a desire to see a timeline for siting and a timeline for greater community engagement around those sites so that we can have a sense of momentum and moving forward and establishment of these sites. So I think it's because of the ongoing work that you're seeing a call for urgency. Yeah, Councilmember Gonzalez.
I just want to lift up the points that Councilmember Juarez was making around the likelihood of needing to apply a racial equity toolkit to this project. And as we do that, I want to make sure that we're looking, I think this is one of these issues that is complex in terms of trying to do that work. Racial equity toolkit work is always complex, but I want to make sure that when we're having the conversation and when the departments are doing the evaluation around the racial equity toolkit, that it's not just about the racial and social justice impacts on the neighborhood where the siting is occurring in terms of the people who won't be accessing services of the project, but really what are the racial equity outcomes that we believe will exist as a result of implementing this project in a location that has been identified by the city and county to move forward with this project. And so I want to make sure we don't lose sight of that nuanced perspective that I think really does get to the heart of what our city's race and social justice initiative is all about.
Thank you for that. All right. So I'm going to talk briefly about the estimates for capital and initial costs.
A little closer.
Capital and initial costs that were included in the SLI response. First of all, the estimates that we have and the operations that are assumed to come to those estimates were arrived at by working with Public Health, our partners at Public Health, and it's based on their experience operating other types of services in the same vein.
Just a little bit closer if you can. Thank you. You can
I'm
pull
a
it
soft
right in
speaker.
there.
So first of all, we assumed a size facility.
Ms. Cuevas amplified you very well.
To amplifying
Not
women's
that loud.
voices today, it is International Women's Day, so.
So we assumed a facility of a certain size to allow a true proof of concept. The square footage assumed for this facility would be 2,000 square feet, and that was to include enough space for 10 consumption stations, staff offices, a needle exchange, reception area, waiting room, restrooms, and storage utility room. All of those components are thought to be part of a successful operation. In addition, we also assumed that the facility was going to operate 7 days a week, with the thought that users wouldn't be taking a day off necessarily, and the facility shouldn't have a day off either. We also assumed 10 hours a day so that it's actually a viable place for users to come and consume. And the staffing assumptions there, 14 FTEs, not all of those people would be on site necessarily at the same time, or they wouldn't be on site at the same time. There would just be a level of staffing sufficient to have education specialists in the different areas of the consumption site and nurse on site, buprenorphine on demand, those sort of treatment services available, case manager, security, and then a facilities manager. In addition, we also put in an assumption for some neighborhood mitigation and outreach, continuing outreach, so sort of something that would be defined and informed by the community engagement process. We don't know exactly what those funds would go towards, but assuming that there would be something for that. And then just the last point there, for the mobile facility option that Beth is going to talk about a little bit later, we assumed that not all of the people and not all of the services would fit into the mobile facility, and that there would need to be an adjacent space that was leased in order to house all of those other services that are the community health engagement portion of the safe consumption site.
Can I follow up?
Councilmember Morris.
So we met with Evergreen, the folks at Evergreen, for well over an hour yesterday on the people that do the mobile piece right now. So when you say that you would need to rent a space, couldn't you just work with a group like that or something akin to that, where you don't need to rent space, but you could actually just, because you're in a mobile unit, they have an RV, you pull up to a medical facility in the parking lot, where you're partnering, where the city isn't actually renting space, but can use an existing facility that's already treating this population?
Yeah, and if there was an opportunity to park a mobile facility adjacent to a place that already was offering some of these services, then probably there wouldn't be that need for so much lease space or any lease space, and that could bring the cost down. These cost estimates were conservative.
Well, I'll tell you right now, my bias is leaning towards that. So I'm letting you know that now.
For the committee's knowledge, I did ask the mayor's office and the crew that we went with Meg, for a fixed and variable cost budget so that we could really see where some of the opportunities are to expand or shrink this budget. So for example, you mentioned 7 days a week, 10 hours a day. I think what we'll see is a scalable budget so that we have a better sense of what funding may be available to us as we look at citation.
And then FAS.
I'm sorry, can I, on one of those assumptions, the 10 hours a day, 7 days a week, can you just tell me a little bit about why you landed on 10 hours a day? Is it strictly related to cost?
Some of it was informed by a qualitative survey that Public Health and the University of Washington did with amongst users, and sort of what they would be looking for in a safe consumption site, what hours they would want to use, the locations that were acceptable. So we drew some of these operating parameters from that study based on the users' qualitative responses.
And what do the qualitative responses of that study say?
Well, primarily that there's, like, they wouldn't use a facility unless it was open enough hours of the day that they'd be able to get there. And it would have to be nearby a location where they were already using, not a place where they'd be riding transit a great distance.
So does the report say that enough hours is 10 hours a day?
No, it doesn't get to that level of specificity.
Can you send me that report, please? Sure. The study that you're referring to, I'd like to evaluate that. I think, I think my concern is similar to the childcare world, where we assume sort of certain blocks of hours are when we're going to provide the service. And part of that is influenced, obviously, by budget constrictions and realities of resources available to us. But, drug use is, suffering from an addiction is a 24-hour problem, not a 10-hour problem a day. And so I think it's important for us to struggle with this, with the realities of our budget and our resource availability with the needs that we're trying to actually address. And so I'm a little concerned about the underlying assumption of the 10 hours, 7 days a week as being perhaps too short.
I think we're in alignment on that conversation when we discussed this, and I think the recommendation that came out of the task force was actually a 5-day-a-week pilot, 8 hours a day. So we have taken it to, the conversation has been people use every day, not only during the week. Right. Let's make sure that we make this a true pilot so that we can really evaluate the impact.
And I think we get closer to making this a true pilot by going from 5 to 7 days. I still think there is. My hope is that we can engage in a conversation about the number of hours a day it's available and what that looks like during 24 hours, right? Does it have to be fully staffed 24 hours? Maybe not. But I think that if we are on a path towards ensuring the greatest degree of success of this program, which in my mind is reducing the number of preventable deaths in our community, then I think we stand a better chance of making that case by making sure that the center and the program and the interventions we are offering are truly meaningfully available to community. And I have concerns about whether 10 hours hits that meaningful mark. It may not, and I just want to flag that as an early concern of mine.
I'll also add that as part of the recommendations, there is an evaluation component attached to the community health engagement locations, and that would be part of that evaluation. Is it real? How are we adequate meeting users' use?
Thank you.
Okay. And then FAS was involved in this SLI response on looking at different types of property that we might use to cite a safe consumption site. We talked, there was a small group of us that got together regularly and talked about different options that might be available for citing a safe consumption site. You'll see the list of the 6 that we developed. One is leasing an existing site. The second is acquiring an existing building. The third is citing in a building already owned by the city or the county. Fourth, citing a portable building on vacant land already owned by the city or county. The fifth is acquiring an empty lot and citing a portable building on that lot. And then finally, citing a mobile facility like the mobile medical van adjacent to a facility that already provides services or would have space available to provide services associated with the CHEL. As was noted in the previous presentation to council, there has been a rapid increase in property values in the city of Seattle, and so the costs associated with this are conservative, meaning that we estimated high, and because we did not want to get into a place where we found a perfect location and be significantly short on a budget. If we did find the right place, the right budget, the right location, the right square footage, but the cost hadn't been accounted for, we wanted to ensure that you were aware of kind of the high end of value in the city of Seattle. And obviously, each of these different sites has different timelines for implementation. So how long it would actually take to get something up and running is really contingent on the type of facility that we're looking at using. So here we are.
Wonderful. Thank you.
Thank you, Ms. Gabbard.
Yes.
And you're at the table for subject matter expertise? Okay, wonderful. And are you located at Public Health Seattle, King County?
Yes.
Okay, wonderful. So the recommendations that came in the slide, were they a joint effort from Public Health Seattle, King County and the City of Seattle?
Yes.
Okay.
We've been working closely with Jeff and Beth and Katie on this.
Okay, wonderful. So I'm sure we have a handful of questions, and we also have a panel presentation after this from some of the folks who've been working in tandem with the city and the county public health to advance the concept and research around safe consumption sites. So before we get to that panel, questions from this slide.
Just really quickly, so I'm sure most of you saw a report that came out from the CDC earlier this week. I think it was on Tuesday is when that report came out, and I'm glad we have a subject matter expert here because I have perhaps a technical question. So that report from the CDC really talked about the rise in opioid overdoses using a metric of how much of an increase we're seeing nationally in terms of emergency room visits ticking up in relation to suspected or actual confirmed opioid use of some sort. And it concluded that nationally there's a 30% increase in emergency room visits as a result of opioid use. One of the things that I noticed digging into that CDC report is that it lists a chart of all of the states that reported percentage changes or data that could be evaluated to determine percentage changes in emergency room visits. And the CDC reported that there was no data available for Washington State. Can somebody, do you know why?
Well, we have not done that analysis. We just received mid funds from the county last year to start doing a little bit more with non-fatal overdose surveillance. Most of the data that we look at are fatal occurrences and look at them by geographic area, but we also have data from police department and EMS that we can look at.
To me, it seems like there's benefit to tracking non-fatal opioid incidents in terms of being able to identify trends either in particular parts of our city or other potential patterns of, for example, particularly dangerous, dirty versions of the drug. And so I'm just wondering whether Seattle King County Public Health is undergoing any efforts to look at some of that upstream data and information, similar to what the CDC did, to be able to help us pair that information up with the effort that we're talking about here.
Yeah, that kind of data will really help us around the citing conversation because we won't just be looking at places where people died, but also looking at the impact on other areas. So we have an epidemiologist who is working with police department and EMS to start gathering that kind of data. So yeah, we'll be looking at it. That's in the shared responsibilities. That's public health's responsibility to look at the quantitative data more carefully.
And are you working with, when you say EMS and the police department, are you referring to the Seattle Police Department and fire?
Seattle Police Department and then, fire.
Okay. Thank you.
Councilmember Juarez.
Yeah, Seattle Fire does collect a lot of information around and very precise and specific information. So we will be working with that data as well.
That's great. And Fire was in my committee last year, giving us a presentation on some of those data points. So I have a lot of interest in making sure that we're able to track that quantitative data to be able to see if we can analyze it and evaluate it in a way that helps inform not only the citing conversation, but programmatic needs of what this program will ultimately need to incorporate.
I had 2 follow-up questions, Madam Chair. So just getting back to the citing issue, because that's going to be a big issue. That's what I've heard loud and clear, particularly in my district. So we know that you guys went up to Vancouver, correct? You saw the Vancouver model, and you know about it, the Vancouver model, obviously, and also it's going on in San Francisco as well, correct?
It hasn't started.
But they're doing this, they're investigating it?
Yes.
Okay.
Yeah.
So are you looking to them to kind of give you an idea when you do the citing, like what is going to be the criteria for that? Is it the greatest need? Did Vancouver just stumble on the spot because that happened to be an open building?
Right. Well, in Vancouver is a little bit different because their drug use is really concentrated in this area, this sort of.
Right, and that's what I'm asking. I'm saying, is that one of the criteria you would be looking at, that where drug use is concentrated, where there would be more medical facilities? Those are the kind of things you're looking at? Okay.
Absolutely.
Okay. So my second
Yeah,
question.
and some of those criteria have been outlined or begun to be outlined in the implementation guide and also in the task force report itself.
Okay, so my second question is on, this is more for the city side. Who ultimately is going to be the lead, quote unquote, agency or department? Is it HSD, FAS, DON? Who is going to be the point department that we as city council members will be going to say, here's the pilot project, here's the money, is it working? You're pointing at people like
Pointing at myself.
You're pointing at yourself.
As
Okay.
with any interdepartmental effort, having a single department lead when it is an interdepartmental team, usually those interdepartmental efforts are led out of the mayor's office. So for the time being, I am that person that you can interact with about this.
But not when it, I mean,
You're talking about ongoing?
yeah, like
Ongoing.
ongoing, like, yeah. the
Ongoing,
medical-
Seattle, the public health department
Right.
will be operating the facility moving forward in an ongoing way.
And they'll be working directly with the mayor's office and,
And HSD.
And HSD.
that's what I'm asking.
Yeah,
HS
yeah, yeah.
So it'll be
FAS
HSD.
gets to move out of it because our real estate experts, they don't have a role in it moving forward. So it will be HSD, public health.
That's
It
exactly
will,
what I needed to hear.
likely sort of move into our public health contract, if you will, and part of our interlocal agreement. And if you think about it, one of the aspects of the interlocal agreement between the public health and the city of Seattle is really looking at the city providing what's called enhanced services, or those services that otherwise can't be funded outside of, from other places. And this is much like what needle exchange was 25, 30 years ago, when no one wanted to touch needle exchange. The city stepped in and started helping to fund needle exchange programs. And so that's in our interlocal agreement. This kind of fits squarely into that.
Let me ask you this. In the interlocal agreement, does it specify safe consumption sites?
No.
Is it going to?
Yeah, no, the interlocal agreement is purposely broad in the sense of just
So I know
outlining.
what one is.
Yeah.
What I'm asking you is that your intent at some point in the interlocal agreement to be specific about safe consumption sites and how we work with the county?
Yeah, I couldn't answer that right now, just because our current agreement is broad intentionally. So
Yeah, I think it's, I brought this up in my meeting with these good folks a couple days ago. I'm already forgetting what it was, but it was earlier this week, maybe yesterday. And one of the things that I flagged is my interest and desire in making sure that there is, at a minimum, of a memorandum of agreement or understanding that relies on both the King County ordinance and the Seattle City Code and the interlocal agreement that allows for partnership in this area. And so I think invoking those as our authorities and memorializing the relationship in this new business area between the county and the city is something that I've asked the executive to please consider doing. I do think, because it is a new line of business, having a memorandum of agreement or understanding is ordinary in these types of situations and is a best governance practice. And I think it's important for us to make sure that we put our expectations down on black and white paper in black and white to make sure that we all have a clear understanding of how the relationship is going to advance.
And that was my concern thank you, Councilmember Gonzalez, is that I don't think that the interlocal agreement is too broad. My concern, not just on making sure that the project is successful and where we cite it and the cost, is I'm concerned about the liability piece. I don't want us 2 years down the road to get into finger pointing where, King County was supposed to do that or City of Seattle. I really want to be specific because I really want success. And if we're going to continue this model and this pilot and move forward, and we're each going to be providing not only funds but expertise and subject matter experts, that we are clear in our intent, that we have a meeting of the minds, how we're going to tackle this crisis. It's not going to go away anytime soon. And so, as Councilmember Gonzalez was saying, again, you got, probably because we're lawyers, I'm always more comfortable when something is more specific than just more broad in an interlocal. If it's an MOU, MOA, whatever you want to call it, I would really encourage that we do that. Thank you.
Great. I think it was just yesterday that we discussed this, so we have heard you, and we'll take that back to the mayor and bring it back to you and figure out.
Thank you.
I think you heard the request 3 times because I also mentioned it yesterday in our briefing. The first question I asked was, how are we going to identify the lead on this issue? This is a priority for our committee, for the council, as you heard from Councilmember Gonzalez. It crosses all of our issue areas, and we want to move forward in 2018. This is not the end of the conversation. We will also be discussing this with the task force and to talk a little bit more about the heroin and prescription opioid task force recommendations on April 19th. I think what we would hope to see in the next month and a half is a better sense of the timeline from FAS in terms of the process and criteria for citation, the timeline from HSD around what it would look like to have an entity up and running and an ongoing budget is sort of established, a little bit more from the request that we made yesterday about the fixed and variable costs. And then I think getting that data that you referenced that was really rooted in a survey from individuals who are suffering from addiction, that is how we want to drive policy, really making sure that this site meets the needs of individuals who need access to treatment and prevention from death. So I'm appreciative that you mentioned that study and would love to see that. We will also be reaching back out to, I think, all of you to make sure that we have a full agenda on April 19th. And there again, I want to express our intent to show some of the coverage from Vancouver, especially from King 5, that really destigmatize the individuals that are using these centers, and also talks a little bit more about how we can learn from other cities, other city examples. Lastly, I'll also say, as we look at these 6 recommendations, I think what I'm interested in is having a better sense of how we are going to drive towards a option here. We have 6 options laid out for citation, and I have a few questions around mobile units, and perhaps you can get back to me if we don't have time today. There was a 2014 report by Dan Otter that looks at mobile drug consumption sites in Spain, Germany, and Denmark, and I'm just wondering, from a public health perspective, we heard earlier from some public health advocates, how we can make sure that this is truly an evidence-based model. As we talk about rolling out a pilot, the outcome should be to make sure that we have a successful program ultimately, and I'd like to hear a little bit more information from those other countries and the cities where they do have mobile units and how they are paired with permanent locations so that people can get access to the treatment and outreach services. Also, I'd like to have a better understanding of what those cities and in the other countries have done to create the services needed within those mobile units. I'm very concerned that if we don't have an actual facility, even if it's a modular facility, then folks will not have access to the treatment services services, which is ultimately what we also want to get them into from a public health perspective. Would love to hear the evidence that we've seen around various models that are proposed in this report. Councilmember Juarez.
Just briefly, we did have a chance to meet with Dr. Molly Carney, who also served on the opiate task force, who, as you know, runs Evergreen. And as you know, we're really diving into the whole mobile piece. And one of the issues that was raised, and I just want to flag it now because it's going to be a concern, I think, for all of us, is that we want to make sure we're ahead of any type of medical discrimination from the 11 hospitals or 7 hospitals we have in this city. And we're looking at that. We're looking at it in other aspects too. But my concern is that if we were to be able to have a mobile unit or something of that, and we were able to work out an agreement and work with other hospitals, I would hope that we have some of these hospitals that are dealing with people that need these services, that we don't experience that, and we should be aware of that. That is a concern that Dr. Carney brought up with me about the whole medical discrimination piece. And this city has a ton of hospitals, and most of them are located on Capitol Hill. U District, one hospital in my district, and I really want to partner with them because they are in some of the clinics too. We have 2 clinics in my district that are already providing Suboxone, methadone, Narcan. They're already doing those things. The neighbors may not be happy and thinking that they don't have heroin addicts in their neighborhood, but they do. They just don't know it. But we know it when they die. And so I want to flag that, the hospitals and the clinics, and make sure we stay on top of that. So thank you.
Thank you. So long as we're talking about data and evidence-based strategies, I want to suggest that we also invite Dr. Richard Haroof and Dr. Julia Hood and Lee Thornhill from Seattle and King County Public Health. Dr. Haroof is our chief medical examiner with the county, and as some of you may have heard, they just recently released a new report on homeless deaths investigated by the King County Medical Examiner Office. And of course, the numbers are pretty devastating, pretty shocking growth in the number of individuals who are experiencing homelessness, who are dying because of opioid overdoses. And so I think it's important for us as we continue down the question of citing and the substantive program aspects of the CHELS that we understand deeply what the problem is we're trying to solve and why this is an important intervention connected to solving that problem, and really fundamentally understanding who the visitors are going to be to the centers. And I don't think we can have that conversation without confronting the realities of who is suffering the most as a result of this. And I don't want to imply that it's only people experiencing homelessness who have opioid use issues. There are plenty of housed people who also have difficulties with opioid, and I do see this as a significant root cause that is leading to housing instability and to pushing people into experiencing homelessness. And so I hope that we can get Dr. Haroof to come in and talk to us as part of our council obligation to really understand the underlying data. And just really quickly, some of the highlights from the report include that the absolute number of homeless decedents investigated by the medical examiner's office has increased from 2014 to 2017 in parallel with an increase in the estimated number of unsheltered persons in King County. We also heard from the medical examiner's office that 30% of the deaths of homeless individuals are attributed to drug overdose, and that obviously is a concerning trend. And then the last 2 data points I just want to share and lift up now is that opioids still remain the leading category of drug-caused deaths among homeless decedents in King County, and the percentage of drug-caused deaths involving methamphetamine are also increasing significantly. So again, that's a really important data point for us to understand and to dig into as we begin to explore how we're going to implement the programmatic aspects of this. And then lastly, or two lastlies, I think that it's important for us to understand that a majority of these deaths being investigated by the King County Medical Examiner's Office occurred outside of healthcare facilities and residences, and of those 72%, 50% occurred outside. And that is a really significant, if that alone isn't enough of a reason to motivate us to act with a sense of urgency and with determination to ensure that we can implement a program that is the most defensible and the most successful. I don't know what is. And the last thing I'll say is that of the deaths in King County that are presumed to be homeless deaths by definition of the medical examiner's office, 47% of the deaths in King County related to opioid are right here in Seattle. So this is very much a public health crisis for us, and it is incredibly important for us to continue to advance the efforts that we have been undergoing for the last 2.5 years, because the numbers don't lie in terms of what the need is and in terms of what our sense of urgency should be around moving quickly.
Thank you very
Thoughtfully,
much.
but quickly.
Thank you very much, Councilmember Gonzalez. Thank you to this entire group for coming. And again, we will revisit this in mid-April. If we could have you all exit this way, we'll bring in our last panel to sort of wrap us up as we talk about next steps with Patricia Sully from the Public Defenders and Mark Koch from the ACLU. We appreciate you coming. As the panels transition out, I want to make a comment. We know that needle exchanges are very common public health practice now. And in 1988, the first needle exchange program in the nation was opened in Tacoma. It took 28 years. In 2006, for the first time, the National Surgeon General recognized needle exchanges as a valid strategy to help address public health crisis in our country. We cannot wait another 30 years for safe consumption sites to be recognized as a valid public health approach. So with that sense of urgency that you heard from Councilmember Gonzalez, from Vice Chair Juarez, we welcome you to the table. We know that you've been involved in this conversation for a very long time and wanted to just get some thoughts from your perspective on next steps and what you've heard. And please introduce yourself for the record.
Hi, I'm Patricia Sully. I'm a staff attorney for the Public Defender Association, and I just want to thank you all so much for having us here today. There's not another group of people I'd rather spend my Women's Day with, so thank you.
And I'm Mark Cook with the ACLU of Washington, where I'm an attorney, and I also represented the ACLU on the King County Opiate Task Force, and just also want to express my thanks for allowing us a seat at the table to talk about this important issue.
Wonderful.
He's also very excited to be surrounded by women.
Thank you. Yes, happy International Women's Day to everyone. I apologize for the short timeline on this. We have about 5 minutes or so, so if you could give us your thoughts and remarks and any comments on next steps would be very helpful.
Okay, great. I'm going to kick it off, and we've heard a little bit about the history of the work that's been done on this issue over the last 2 years, but I wanted to highlight a couple of additional points. So we are now at the 2-year mark of when the King County Opiate Task Force was convened by the City of Seattle and the county, which embarked on a long, community-driven process in a lot of ways, which resulted in the 8 recommendations lined out in the report from September of 2016. Always want to be mindful that the consumption space is one of 8 recommendations for that task force, and we really need to keep our eye on all of them. After that, the Board of Health in January of 2017, fully endorsed the task force recommendations. And I think one important point, especially going to some of the legal structure of all of this, is it really comes from public health authority, which is very broad. And it is a response to the epidemic that we see that these recommendations flow through public health authority and how that is set up in state and local law. During that process, I want to quote our felony prosecutor, Dan Satterberg. quote unquote, "I want you to know that in this drug crisis, I believe that the criminal justice system should not take a primary role and that instead we should follow the lead of public health professionals. I pledge the support of my office to the task force recommendations, including the establishment of safe consumption sites for drug users." We also heard from the State Board of Health in response to community concerns about these efforts that, quoting them, "Local health jurisdictions such as Seattle and King County have broad authority to take certain actions in response to local health crisis, such as the opiate epidemic. We believe that this is the approach that Seattle and King County are taking as they plan to open community health engagement locations, which include safe consumption sites." From that, following the public health model, appropriations were made by the King County Council and now the Seattle City Council to implement those public health interventions. And also want to be mindful that, it was June of 2017 when the King County Council appropriated funding for this, and those timelines, can be eaten up pretty quickly, right? And you don't want to leave money on the table for doing this. So I just think it's important to kind of understand the historical background of this and really noting that it comes out of public health authority in the first place.
Thank you. Hi, and thank you all for the thoughtful way in which you're engaging in this conversation. And I just want to talk a little bit about citing considerations. So I also was a member of the King County Task Force, and we really talked a lot about citing. And some of those things have already been touched on here, right? We want to cite in a place where there's already outdoor drug use or public drug use. It doesn't make sense to put this in a neighborhood where that activity doesn't already exist. One thing that the task force also recommended was a fixed site over a mobile unit, which is not to say that a mobile unit cannot be an effective way to go about this, but I think as we think about, what is the most effective site, we want to think about where we put it, and we want to think about how we operate it. So fundamentally, this should be a relational encounter, not a transactional encounter, because we know that it's the relationship that is really going to change people's lives. So we want to think about considerations like, how does drug use actually work, right? What does it mean for someone who's using drugs, who's normally doing that in isolation and is now doing that in front of someone else, which is an incredibly intimate experience and one that has the power to forge an incredible bond between healthcare worker and client. But we have to have the right space for that bond to form, space where that person who's engaged in drug use can do it in a way that feels comfortable for them. For a lot of people engaged in drug use, there's a tremendous amount of ritual around their drug use. So they're engaging in a certain way, right? They're doing a certain set of steps. They may lay their materials out in a certain order over, a certain amount of space. We want to think about, do we have enough space for that person to really engage in a way that they're going to want to use the space and not revert back to just using whatever bathroom or whatever alley they were using before, right? Have we created a space they want to enter into? And have we created a space that feels safe, that feels private? And there are questions about how that works in a mobile unit. A mobile unit is inherently limited really just to that injection or consumption, so everyone walking into it basically has a flag on their back why they're going into that, as opposed to a fixed site where it's embedded in a broader array of services. So people are entering into that building for all sorts of reasons. So people may feel much more comfortable entering into a fixed site location as opposed to a mobile unit. So I think those are the kinds of considerations that should also be being discussed and thought about as we think about, not just where we cite, which is of course an incredibly important decision, but how we cite. What does the actual model look like?
We could do both because, right now it's an emergent situation. I don't want to wait for brick and mortar, quite
No,
frankly.
absolutely.
And meeting with I say Dr. Molly, but and seeing what Evergreen and how successful for the last 20 years, what they have done. And it's not just transactional when they're dosing people. It is relationships, and they are getting people stabilized. They are getting people, meeting people's needs when they relapse. They are getting people into treatment, into housing. I mean, they've proven successful. So I'm a little bit, I'm going to push back a little bit on, I think you can do both.
No,
But because
absolutely.
we're in an emergent crisis, that's what I'm concerned about. We can go on and on about when brick and mortar is going to happen and what neighborhoods are going to come out and say, we don't want it here. That's what I'm concerned about.
No, and nothing I'm saying is meant to say that mobile units can't be used and wouldn't be effective, and that's not what the task force said. The task force just expressed, a preference for fixed site if possible.
me too.
So I'm really just raising questions about how we implement, and it is possible that, maybe in this emergency moment, mobile units are where we can and should go first, but I think we should constantly be thinking about these questions of how, as we set those up, do we do it in a way that is really going to be an effective program? Because if no one comes, we can't save lives. Right. So we have to really set those units up to be a place that people want to enter into.
Can I just quickly add on the kind of community engagement process going forward? I'm very heartened to hear that, timelines are important, right? And I think just from a community advocate's perspective, you don't want it to be too open-ended, right? And that, if this is an emergency, it can't just be sort of these endless horizons, right? And certainly community engagement, which is again noted in the task force citing criteria, is crucial, right? But that it really should focus around those citing criteria, right? And be conversations in the places where these facilities are likely going to be going, and not so open-ended, right, that it's just going to sort of get bogged down in the underlying debate of these, right? And really trying to go back to my original point that this is a public health intervention being called for by our public health authorities, and we need to get it implemented. And the comparison to the needle exchange story in the late 80s and early 90s is really the best kind of analogy for doing this. And if we had waited for kind of overwhelming consensus from locals or state or feds, we would not have those facilities now. And I would. So many people have been saved because of that intervention, and we need to do the same thing now.
I don't think anyone's saying we need overwhelming consensus. I mean, we're never going to have that. I mean, let's just be honest. That's just not going to happen. It's not an accident that 5 cities pass ordinances that they don't want safe consumption sites in their neighborhood. And sometimes when there's a public crisis, a public health crisis, they really don't have a choice. And I think the court was very clear about that. What I find the irony in that is, of those 5 cities, 2 or 3 of them have some of the highest levels of overdoses in rural King County, which boggles my mind that you wouldn't want to have to save lives. So this crisis started in rural counties, it's in cities, it has ravages Indian country to the point where people don't even know the stats anymore. I mean, it's worse on Indian reservations than it is in a city right now, as we know, for the last 3 years. So as you're shaking your head, it boggles my mind that they would say, well, no, we don't, it's okay, we don't want that here. They're already here and they're dying. Yes.
I want to applaud the task force for the work that you've done to have community conversations already. You mentioned over the last 2 years. It would be helpful as we have this conversation going forward, especially next month, if you could bring forward some of the conversations you've had, and also let me know. My understanding is that at least within the city of Seattle, there's around 70% of the population that's supportive of this concept. And I think what we want to do is recognize, yes, this is a regional crisis. In fact, this is a national crisis. To the extent that Seattle can show leadership, advance the concepts, the public health proven strategies here to save lives and get individuals into treatment, we want to again be a leader in this area. Your conversations over the last 2 years can help inform our discussions going forward. You heard all our call and our commitment to make sure that there is a timeline in front of us for 2018. I also just want to ask is if the task force is making any further recommendations or convening in response to the Statement of Legislative Intent report that we received back on the 6 recommendations. Your comments or thoughts on those 6 options are welcome, and I know it's rooted in evidence, so we would welcome that feedback as well. Any additional comments, Councilmember?
I just want to also echo my thanks and gratitude for you all and the work that you've been doing in terms of the last 2.5 years, really educating us, educating other elected officials, or at least trying, and some of them just don't want to get it, and really, helping to frame this conversation in a way that is productive. And in a period of time in our civic discourse where framing controversial issues in a way that is approachable is, frankly, a rarity these days. I'm really appreciative of your efforts and your desire to want to work with the city in partnership and with communities who might have concerns about this in partnership to really make sure that everybody's hearing each other as we all collectively struggle with the reality of the opioid crisis. And those are tough conversations to have, and they're ones that we really need to have. And I appreciate the thoughtfulness with which you all have approached the community engagement work over the last 2.5 years. And I hope to see that continue, of course, thoughtfully, but with a sense of urgency. That's going to be my tagline here on this one.
Not mine.
And you don't want it to be thoughtful or urgent?
I don't.
Okay.
Just kidding.
And so I think, I'll also just add that that as we continue to do this work, part of the conversation that I think sometimes we don't include in our conversations around this is, we tend to talk about the worst outcome possible of opioid drug use is death, right? And it is. That is, I read some statistics that show that is true. When we talk about why this is a public health strategy, I think it's also important for us to remember about all the other shy of death public health concerns that a CHEL that includes a safe consumption site, like a needle exchange program, helps to prevent and mitigate and treat, right? So, hepatitis, AIDS, HIV, all of these things are things that we could address through this public health strategy as we move forward. And so I think it's important to talk about the full spectrum of potential outcomes that includes preventable deaths, but also includes a lot of other types of public health concerns that fall clearly under the rubric of our public health authority as a local jurisdiction to address.
Thank you. As we close, I just want to again welcome any feedback you have as we look forward to next steps on not just this report, but the overall recommendations that come from the task force. You mentioned earlier, this is one of several recommendations which we will be highlighting at our April 19th meeting. Again, this is going to require a public health approach that has all hands on deck, that takes the research, the evidence-based research that you and so many others have done and puts it into action. We look forward to talking with you again and to making next steps.
And I hate to be annoying. Can I bring up one last thing?
Absolutely. Never annoying.
I think that part of the presentation that we heard from our city staff and partners at King County is that they're painting a very clear picture for us about the price that this will cost us, depending on the model. But even the mobile site model is much more expensive than what we currently have budgeted through general fund dollars. And so I think we, in advance of our budget season, it's going to be important for us to identify a revenue stream to support this council and mayoral priority moving into the fall. So I have some ideas about that, and hopefully we'll be able to make sure we don't lose sight of the conversation around the fact that it's an expensive endeavor. It's one that's worth paying for, but we do need to identify a revenue stream to be able to support this program.
And make it successful, absolutely. Yep. Thank you very much to both of my colleagues. Thank you to this panel and to every panel here today. The next meeting of the Housing, Health, Energy, and Workers' Rights Committee will be on Thursday, March 15th. We will be talking about the confirmation of the Office of Labor Standards Director and the Domestic Workers' Bill of Rights. Again, noting that today is International Women's Day, and much of our work is, yes, paid for, but a lot of it's unpaid for in the home as well. We will talk about domestic workers and advancing their protections in the home. Thank you so much. This meeting is adjourned.
Thank you, guys. Thank you, Patricia.